Welcome, everyone, to COVID-19 Pandemic Response for Nurses. My name is Tenor Venema, and I'm a professor of nursing and public health at Johns Hopkins University and president and CEO of the Tenor Consulting Group. This course is brought to you on behalf of the National Council of State Boards of Nursing. I want to welcome you to our course and provide you with a brief overview of what you can expect as we move through each of the three modules that constitute the main body of this course. This course is designed specifically for nurses, in particular working nurses who have been asked to respond to the overwhelming demands posed by the current COVID-19 global pandemic. Recognizing that nurses need current, valid, and reliable information, and that they need it right away in order to be able to function successfully across multiple roles in pandemic response and at the same time keep themselves safe, we have designed this course to meet just those challenges. The course consists of three main modules: COVID-19 pandemic, what nurses need to know; infection prevention and control basics, and selection and use of personal protective equipment; and legal and ethical issues in pandemic response for nurses. The course faculty for this COVID-19 pandemic response for nurses include Dr. Mary Pat Coig, Dr. Christopher Fries, Dr. Roberta Lavin, Dr. Christine Qureshi, and myself. All of us have worked in public health emergency preparedness and response for many years, and we are pleased to bring you what we believe to be a well-designed, very comprehensive course to help nurses get the information they need to be able to go to work, stay at work, and then come home safely to their families and communities. This is a very interactive course, and we're really excited to bring this to you. We've used the Creative Commons course platform to create a series of three ThingLink online modules. And ThingLink is a very interactive program for presenting content, but also providing you with active real-time links to additional resources. So this is very much a participant-driven course. You will be able to spend as much time as you need on each module, and so it allows you to customize the course to your learning needs. All of the content contained within this course is evidence-based wherever possible and competency-driven. We draw from the highest quality resources from verifiable sources. So, for example, the Centers for Disease Prevention and Control. Web links are provided to additional vital resources for you to be able to read more and learn more about any component of the module that you feel you'd like to learn a little bit more about. So let's start off with a brief overview of COVID-19. Coronavirus disease, or more commonly called now as COVID-19, is caused by a new novel coronavirus, the SARS-CoV-2 virus. SARS-CoV-2 is a beta coronavirus, an RNA single-strand virus that's very similar to MERS-CoV, which was the Middle Eastern Respiratory Syndrome virus, and SARS. COVID-19 had a zoonotic origin, meaning that it came originally from an animal that was transferred to a human. SARS-CoV, MERS, and SARS that we saw back in 2003. All three of these viruses have had their origins in bats. The RNA sequences from patients here in the United States are very similar to the ones that we've seen in China that were originally posted when this virus was reported in Wuhan, suggesting that there was a single recent emergence of this virus from an animal reservoir, most commonly suspected to be a bat. Because this is a novel or new virus, there are still many things that we really don't fully understand about how this virus works, although we have made great progress over the past 3 months in learning more and more about the virus. So, a quick overview of COVID-19. The symptoms primarily present similar to any other influenza-like illness. A typical patient presentation would be someone presenting with a fever equal to or greater than 100.4 Fahrenheit, a cough, and complaints of shortness of breath or difficulty breathing. We have learned that asymptomatic COVID-19 is possible. The severity of illness is a very wide range, everything from people experiencing very short, mild symptoms to severe illness requiring hospitalization and intensive care. As of now, we believe that approximately 80% of patients who contract COVID-19 can expect a mild to moderate course and will hopefully recover without any assistance from the healthcare system. Clinical disease usually becomes apparent somewhere within 2 to 14 days after exposure. And we've believed that the groups that were at highest risk for contracting COVID-19 or for having the most severe cases or potentially death are those over the age of 65, those with immune suppression, and underlying chronic diseases such as hypertension, diabetes, and COPD. Modes of transmission for catching COVID-19 are certainly person to person, including respiratory droplets when someone coughs or sneezes, close contact being within 6 feet or less of a person, and we also believe that airborne inhalation is also possible. Indirect contact, such as touching a surface that the droplet has landed on and then touching your face, nose, mouth, or eyes, and inoculating yourself, can also transmit the disease. In terms of COVID-19 viral shedding, we're not exactly sure how long patients shed the virus. It's possible that SARS-CoV-2 may be detectable in the respiratory tract for several weeks after the onset of illness. However, we're still not totally clear whether that means infectious virus is also present. And as I mentioned earlier in this webinar, asymptomatic infection with SARS-CoV-2 has been reported. I think what's most important for nurses is for them to recognize that by virtue of having close contact with patients with confirmed or suspected COVID-19, that it puts nurses at a much higher risk for contracting the disease. And certainly being within 6 feet of a patient with known or suspected COVID-19 for a prolonged period of time definitely raises the risk. Of highest risk is when nurses are involved in caring for patients where they may have direct contact with infectious secretions or participating in any sort of respiratory procedures such as suctioning or intubation where you're exposed to a higher load of viral particles. So let's talk about the spread of this disease. As I think we all know at this point, it was first reported from Wuhan City in the Hubei province of China. On January 30th of this year, the World Health Organization declared an outbreak of a public health emergency of international concern, and by March 11th, the World Health Organization had declared COVID-19 a global pandemic. This is a map of all of the countries of the world, which pretty much every one of them has experienced a positive confirmed case of COVID-19. Here's an example of the coronavirus global cases map, which is sponsored by the Johns Hopkins University. This was a snapshot of what the map looked like back on March 13th, with 135,000 confirmed cases and almost 5,000 deaths. Less than a month later, we've jumped to 1.7 million cases and over 100,000 deaths, documenting the rapid transmission and spread of this disease.
As the COVID-19 pandemic spreads, many attempts have been made to model where this pandemic is going to go in terms of how long it will last, when it will peak, and when the number of cases will begin to drop off. To date, this has been difficult to do because testing has been delayed across the United States, reporting has been problematic, and in all likelihood, there are many more cases than we have currently confirmed. The numbers of COVID-19 positive patients will increase as testing increases. And because of this delay in doing population-wide testing, we don't really have a clear denominator for the disease.
Across the United States, emergency departments were functioning in a disaster mode almost on a daily basis before the COVID-19 pandemic spread across states and communities. This has required that hospitals and emergency departments surge up to meet this additional demand for patient care. And surge capacity across hospitals and public health and acute care health systems has been a challenge, and we've seen that in all of the states that have to date experienced a large number in COVID-19 patients. Supplies, equipment, staff, space, all of these have presented challenges, and as a result, hospitals have needed to look at redesigning workflow, reassigning staff to different areas, and even establishing satellite centers of care to handle the large number of patients who require critical or intensive care. And of course, nurses are critical to this surge capacity and pandemic response. So what is unique about nursing during pandemic response? Certainly, our models for triage change as we seek to identify and group those people who are suspected of potentially having COVID-19, who are known to have been exposed, who test positive and are definitely infected, those who have been died from it or recovered, and then hopefully at some point we will have a vaccine for this disease. The other thing that's unique about nursing during pandemic response is the need to allocate scarce resources, use personal protective equipment, implement disease containment strategies, manage all of the overwhelming challenges presented by this event, implement an incident command system, and really move to transition to models of crisis leadership and very decisive managerial decision making, often with incomplete information. Many hospitals, particularly in the New York City area, where we've seen the largest number of cases to date, have moved into having to implement crisis standards of care, which by virtue of the definition mean that the demand for healthcare services and the number of patients simply overwhelms our capacity to respond. Because of that, we're often forced to allocate our scarce resources as we try to do the greatest good for the greatest number of patients with the least amount of harm. Often, this means that difficult, painful decisions may potentially lie ahead regarding the allocation of these scarce resources. And as we continue to see an acceleration in the COVID-19 pandemic as it spreads across the United States, planners are working hard to secure additional personal protective equipment, medical supplies, ventilators, and other therapeutics in order to not only care for patients, but be able to protect nurses and keep them safe and well. We're also looking at a need to be able to rapidly increase critical care capacity in those cities that have really seen a large uptick in the number of confirmed COVID patients. And so all of us as nurses need to consider the changes that need to take place within the workplace in order to rapidly redesign workflow and protect patients and nurses. So it may be looking at trying to solicit additional staff to come in and help out with rendering patient care. It may be a need to develop cross-training programs in order to help partner nurses who perhaps have been assigned to critical care or intensive care areas where they've not done that type of nursing before and will need some additional education and training and partnership with an experienced critical care nurse in order to rapidly upskill and learn what that nurse needs to know to be able to continue to care for patients. And of course, we've already seen an effort in hospitals in these hotspot areas to try to conduct reverse triage, meaning to discharge patients to other healthcare facilities or to home if it's safe to do so to open up additional hospital capacity. It really is a time where we have to think about things like team nursing, where the most seasoned, experienced nurse may be assigned to do more of the more advanced procedures and caring for patients, to redesigning basic nursing duties to reduce the amount of face-to-face time nurses have with patients, and in order to reduce the potential for healthcare worker infection. This is a time where we really have to reconsider our traditional staffing models and ways of making patient assignments, and even consider reducing non-essential nursing activities. So just to touch base on the three modules that you will be working through as part of this course. I've mentioned the first one, and it will be more of an in-depth overview of the COVID-19 pandemic, providing you with very specific information that nurses need to know. The second module will cover infection prevention and control basics and the selection and use of personal protective equipment. This is really, really important that nurses understand surveillance of this disease and detection strategies, how isolation and quarantine are disease containment methods that we need to understand very well, standard contact and airborne precautions, and of course, proper hand washing and cough and respiratory etiquette. And this module will cover in detail the selection and the appropriate use of personal protective equipment in order to keep yourself safe. There's a lot of information on what nurses can do to protect themselves, even in times of PPE shortages or restrictions on its use. And of course, it's really important that nurses need to monitor their own health on a day-to-day basis and should they develop symptoms, to seek care and to self-quarantine pending testing. The final module will address those legal and ethical issues that arise during pandemic response, specifically for nurses. And we will also provide you with some up-to-date resources for getting answers to questions that you may have about your ethical duty to provide care and not abandon your workplace or your patients, our duty to benefit and to prevent harm. In times like this, to render and allocate resources in a systematic, fair, and equitable manner, and our duty as nurses to always be prepared to respond.
Of course.
A lot of our information will come from the Centers for Disease Control and Prevention, which is our gold standard for public health guidance within the United States. And I have also developed a number of resources that are specific for nurses, nurse midwives, nurse anesthetists, for disaster nursing and public health emergency preparedness.
Is to flatten the epidemic curve and to reduce the number of patients presenting that could potentially overwhelm the healthcare system.